There are a lot of false positives because the initial indicators are going to be increased heart rate, tachycardia, fever, increased respiratory rate, on low blood pressure. And there are a lot of other things that can cause that. Just an anxiety disorder can cause that, or somebody that is other things going on. Post-surgical patients also can have some fevers post-op that are not sepsis. So you do get a lot of false positives. However, that's where the bedside nursing comes in, or the rapid response teams come in. They can decipher what if this is really if it looks like sepsis or not. And the ones then that do look like sepsis, then the bedside nurse or the rapid response team would then bring us into the bedside once they believe that it's true sepsis.
Yeah. Are you using any other algorithms in the ICUs that are preventing other bad outcomes right now, or is that the main one?
It's right now we're using mostly just the bedside nurses and the monitoring. That's really what we're using. There are some larger hospitals have different things set up to their monitors or to their EMRs that will then alert bedside nurse that something bad could be happening. I think there's the Richmond system also can do that. But for the most part, it's just what the hospitals have already set up.
Yeah, I like to hear about the technology because I remember this you, and you had a lot of, it was like a command center. I presume now it's down to an iPhone level and FaceTime. It's probably a little bit more complicated than that.
Actually, so everybody's so into the technology, just you are, which is great. I love the technology part also. But so yeah, in my office, my home office, I've got my laptop and I've got a big monitor screen. And just I like the multiple screens because I can be looking at the patient on one screen, having the EMR open on the other screen. So while I'm talking to the patient and the patient's family, I'm scrolling through the EMR, I'm looking at the lab work, I can pull up the x-rays. I can actually take the x-rays that are on my screen and put them into the cart and show them to the patient and to the patient's family. That's where the technology comes in. But really, it's the force behind the technology. Actually, when I do a talk, I use a couple of slides from The Wizard of Oz. Big Oz and the wizard. He's got all these things going on and the puffs and the fire and stuff like that. But actually, it's the guy behind the scenes that's actually managing everything and running everything. I think that we're like that also. And that was the initial thing that I had with the robots, is that it's what they can do, what they can do, what they can do. But it's really how we use their technology. So really, you're right, George. We can do video visits right from our iPhone right now, which is very cool. I like to have a secondary screen at least up so I can see the patient's chart and actually do some charting while I'm talking to the patient and looking up the stuff, looking up their data and stuff like that. It also helps because as I'm at the bedside, as I'm talking to the patient, I can actually be putting orders in. I become more effective with all of this. Now, on the other side, the carts and the robots, and the major difference between the carts and the robots, the carts I refer to as it's a monitor on wheels, where you've got a monitor, you've got a camera, and you have to have one of the staff push you and pull you around. The robot it's more sophisticated where we can actually drive it with our mouse and so forth. The last one, the third one that I'll talk about is some places have a screen and a camera installed in the patient's room. This is the least one of my favorites, is the TV, the monitor, and the camera in the room, because you're not mobile. And lots of times what I'll do is before we go in to see a patient, I'll do a quick little huddle with the nurse. What's going on with the patient? What are the concerns? How's the family? To see what's going on, even to find out some of the drips that the patients are on, because we can't keep up minute by minute with the drips. And when we go in and we say, what's the levofed going at? It's a normal question for us, but the family interprets it as, why don't you know what the levofed is going at? Well, it changes every minute type of thing. So we don't want to give that impression.